Hello everybody. Welcome to one of our capacity building webinars from the School for Social Care. My name's Yvonne Burks. I'm a professor in York and I'm the lead for capacity building at the school. And I am absolutely delighted today to welcome Michelle Corns, who's going to talk to us about realist evaluation and reviews. It is a stadium sellout gig. We had to open more places because it's just so popular. So the way that these work is that Michelle's going to talk for about 45 minutes, 50 minutes, and there'll be time for questions at the end. Now, sometimes we give people the option of just waving at me, but there's so many people, I'm not going to make life difficult for myself by trying to find the waving people. So what I'd like you to do is either put your question in the chat or else just put a thumbs up or a question mark, and then I can come to you with questions. And obviously there's so many people, I'd be surprised if we get through them all, but we'll do our very best to do so. It's important to know that this is being recorded so that we can make this available later for people who weren't able to join us here. And our presentation slides will be available after the event. So often people ask about that, but they will be, so you don't need to worry about that. If you're going to tweet about this, would you kindly mention the NIHR SSCR in your tweets? It helps us a lot. And I think that is probably all I have to say. It's nice if people can keep their screens on, because then it makes you feel like you're presenting to people and not a void. So that would be great. I think, yeah, that's probably all I have to say. So I think I'll hand over to Michelle, who will talk, and then we'll, when she's finished, I'll pick up the questions there. You can put questions in the chat as we go along and they occur to you. You don't have to wait till the end, and I'll try and pick them up as best I can. Okay, take it away, Michelle.
Okay, thank you, Yvonne. Good afternoon, everybody. Just hang on. Oh, there we go. Okay, what I'm going to do in this presentation today is to present a case study about how to apply realist evaluation in a complex policy area that really, it cross-cuts health, housing and social care. And really the aim was very much to try and look at the use of realist evaluation in kind of social care settings. What I'm going to do in the 45 minutes is start off with some very sort of brief background about the programme that we evaluated, the Homeless Hospital Discharge Fund. I'm going to explain what realist evaluation is. I'm going to talk then about how we arrived at a tentative programme theory about what works, then look at about how we tested this theory, and then how we made sense of the data and reported the findings. And we was just chatting to Yvonne beforehand, and I really do not claim to be an expert in realist evaluation. It's just we kind of had a go at using it. So it is really just a very practical case study. Just to give a little bit of background to homelessness. So this is really so that you've got some of the context in mind for later on. I mean, in the UK and in England, the number of homeless people has absolutely skyrocketed, gone through the roof since the impact of the austerity measures. Back in 2010, the numbers were dropping and, it was felt we'd nearly got on top of rough sleeping and things, but austerity has just sent the issue through the roof. We've lost a lot of the key housing support services, so it's a real problem. Just to say, homelessness is not just a housing issue. We often use the term trimorbidity, which really means it's like an overlap of very complex issues: mental health, drug and alcohol issues, and physical health issues. So this is things like frailty. You might be 44, but your frailty levels might be that of an 85-year-old. So it's really complex health needs. We know these are quite old figures now, but people who are homeless, they access A&E 5 to 7 times more than the general population. They stay in hospital 3 times as long. and the costs, the unscheduled care costs, are 8 times higher than that of the housed population. The average age of death of somebody who's got a history of sleeping rough is 44 years and 42 years for women. And the current situation, is increasingly been described as a public health disaster. And that was by the British Medical Association. One of the big problems is that when people who are homeless go into hospital, this can be a huge window of opportunity to address these issues. But back in 2012, it was reported that 70% of people who are homeless are often just discharged straight back onto the street without having any assessment of their health and social care needs. In response to this, in 2013, the Department of Health released a 10 million cash boost, and this was to improve hospital discharge arrangements. And with this funding, 52 hospital discharge schemes were established in a wide range of areas across England. In 2015, King's College and partners, this is a big team, UCL, LSE, Liverpool, Plymouth, we were commissioned to undertake a realist evaluation of this particular programme. Okay. Just to say a few words of introduction of what is a realist evaluation. Well, a realist evaluation is a theory-driven approach based on the realist philosophy of science, and the key question is what works, for whom, under what circumstances and how. And really, realist evaluation comes from the perspective, there are no silver bullets to the problem of discharge to a street, and nothing works everywhere all of the time. So if we picked up the hospital discharge scheme from St Thomas's Hospital in London, which has the highest number of homeless people, and put it where I live in Cumbria, into the Cumberland Hospital, one of the smallest hospitals, the scheme, it might work, but it certainly wouldn't be cost effective. And what realist evaluation is doing, it's looking at interventions which work and which pieces you can pick from one area and put in another. So we're really concerned with what's often called the relationship between context, mechanism and outcome. Now that sounds very straightforward, context, mechanism, outcome, but one of the big debates in realist evaluation is about how we deploy the term mechanism. And these are really, one of my favourite papers is by Sonia Dalkin and colleagues, which really explores how do we use mechanism in realist evaluation. Mechanisms are not the programme, they're not the services, but it's people's response to the services that is the mechanism that leads to a change in outcomes. And the sort of example that is often given is, a CCTV camera. It's not the camera that leads to a fall in crime rate, it's how potential criminals view that camera, and does it put them off committing crime in that area. So it's the mechanism is the change in reasoning, how that service impacts in the area. And basically in our study, and I like this because it looks like I can do maths when you do these nice fancy adds and pluses and things. So the formula we used in our study is the mechanism. So that is the interventions, the resources, the extra staffing. We looked at the context, working in London and Cumbria, and then the mechanism, what changes did that bring about with regard to how homeless people are treated in hospital, and what was the outcome? And the outcome for us is ending discharge to the street and increasing safe, timely cares. The reason why we selected realist evaluation to look at this is that, in a lot of policy documents now, we can see that kind of a realist philosophy is sort of, is taking hold, is embedding. So in this guidance, quick guide discharge to assess, it recognises there's no one model, there's no silver bullet, and that what is required to deliver safe, timely transfers of care is a complex adaptive system with simple rules rather than rigid inflexible criteria. And basically what our research has done is what are these key components of a complex adaptive system? And really, can we arrive at, we're not going to say, I mean, one of the biggest things in this research is we constantly ask which of the 52 schemes is the best, which shall we implement? And we have to keep saying it's not a model, it's not the model that works. What it is the bits and pieces we need to put together. So really what we were trying to do was produce a roadmap of things to consider to arrive at safe, timely transfers of care. The first step in a realist evaluation is, in a sense, arriving at an initial tentative programme theory about, views about how and why do you think an intervention is going to work. And then throughout the realist evaluation, what you're doing is you're testing this initial tentative theory, and that theory is refined and recast over the evaluation till you get to a point where you think, yes, right, this is the message for commissioners. We think we're there. And again, just to keep reiterating, the main outcome of interest for us was safe discharge, ending discharge to the street. So how did we arrive at our initial tentative programme theory? Well, before I worked in homeless, I worked with Jill. I can see Jill's on the line, and we were involved in the evaluation of the NSF for older people, and this is a long time ago. But I kind of remembered from that study that at that time, in tackling delayed transfers of care, there was a massive drop, there was a huge problem. We had the NSF for older people, and those numbers reduced. And our evaluation looked at the different mechanisms that had achieved that. And we knew that in reducing these delayed transfers of care, we knew that the biggest thing that had worked was step down intermediate care, basically providing older people with somewhere where they can go after hospital to stay for 6 weeks to recover. And we knew that there was other things. There was like protocols for managing system flow. There'd been the introduction of the delayed discharges Act, where the hospital could charge social services, and the cross-charging wasn't the mechanism that worked. It was the fact everybody was scared to death of getting a Section 5, and those protocols were really effective. And we also knew that multidisciplinary team working, that was really important. So we knew to improve discharge for older people, we had all these mechanisms, we had a jigsaw, and those sites that were most effective had all the pieces of the jigsaw. And our initial tentative programme theory that we tested was, I thought these are exactly, these will work as well for people who are homeless. So really we wanted to look at these specialist hospital discharge schemes and see if they had these jigsaw pieces. So key in a realist evaluation is to be clear and to really write that theory down at the start. So ours was that achieving consistently safe, timely transfers of care for patients who are homeless will depend on localities developing complex adaptive systems that are underpinned by clear protocols, multidisciplinary discharge coordination, and step-down intermediate care. And we label these are our mechanism intervention resources. And in our NIHR report that we produced, the reviewers didn't like all these MIR1 and MIR3. They didn't like us using those terms because it looked messy. But they're our codes. When we're collecting data and we're coding, we're using these all the time. So they become the codes for your analysis. The next step in a realist evaluation then is a realist synthesis of the literature. And this is a literature review. And in a realist synthesis, it's a bit different to a systematic review in that what we're doing is we're interrogating the programme theory. So we basically looked at all the literature on homeless hospital discharge, and we looked at everything to see, could we find evidence of multidisciplinary working, of step down intermediate care? What did that literature say? And overall, the literature supported that. There was some step down schemes that had been set up and they showed really work well. There was multidisciplinary working. So we thought, yes, we're definitely along the right lines. However, when we looked at the literature, we found a new mechanism a new resource that wasn't in the older people's literature that we'd totally missed. And this was the fact that for people who are homeless, delayed discharge isn't the problem. The problem is early self-discharge. So basically, a lot of homeless people are coming into hospital, they've got a heroin addiction. If they don't get methadone or if they don't get their alcohol detox sorted out, they will leave before treatment is completed. Behaviour, if rattling behaviour will be bad, and the hospital will make them feel so unwelcome and so uncomfortable that they will just leave. So for homeless, the other important thing to consider is early self-discharge. And this had been addressed in a number of hospitals by creating what are called pathway teams. And these are teams of nurses, GPs and social workers who work in the hospital, and they've got absolute specialist knowledge of homeless patients. So for us, we revised our programme theory. We had an extra jigsaw piece, which is patient in-reach and advocacy. So again, step 2, we've revised the theory. The next bit of the analysis is then to look at, we've got these 52 hospital discharge schemes. And basically we collected as much information about these schemes as we could, evaluation reports, documentary analysis about eligibility criteria, as much as we could. And again, we interrogated these of who was doing multidisciplinary coordination, who had a step-down service, what did this look like? And again, we found that a lot of the schemes, some, there were a real heterogeneous bunch of schemes, and some had jigsaw pieces and some didn't. And there was it was really hard to make sense of all these different schemes and to pick which ones we were then going to evaluate. So we identified 2 typologies of scheme. There were schemes that had like the pathway teams in the hospital, but they didn't have any step down. So once the homeless patient left hospital, that was it, the support ended. But then there were other schemes that had a pathway team, but then they also provided support for 6 weeks after people left hospital. And we were also interested in looking at standard care. And by standard care, we meant areas where there was no scheme, no mechanism intervention resources, nothing. And again, if our hypothesis was correct about areas, the jigsaw pieces, typology 2 would be more effective and cost effective because it had all the jigsaw pieces. And this is like quite a simplistic summary of the thing, because then with like codes and nodes, we had lots of other different mechanism intervention resources. So step down could be residential, it could be in the community. We also saw some patient in reach, not clinical teams, but just a housing worker in reaching into the hospital and staying in touch with people for 6 weeks. So there was a lot of complexity, and we found that the notion of the mechanism intended resources quite helpful in making sense of that. Now, I'm kind of aware that looks all very, very abstract and very technical, and I just wanted to spend a minute to explain what did that typology 2 looked in practice, how was it working? And excuse me, Bradford was one of the areas, it was one of the best schemes we looked at because it had virtually, very few areas had all the jigsaw pieces, and Bradford was an area which had everything. So if you went in hospital in Bradford as a homeless person, you would get some support from a team in there, the Bradford Pathway Homeless team. They were nurses and housing navigators. And they would sort out your methadone. They would make sure you had clean pajamas because, of course, you're coming into hospital and your clothes are dirty. They would make sure you had toothpaste. They'd give you a voucher so you had a bit of money. So they really made the stay in hospital pleasant. The minute you were sort of medically fit for discharge, hospital discharge was no trauma at all. You just got in a taxi and in 10 minutes you were in Bricks, and this was the Bradford Intermediate Care Centre. It was run by Horton Housing. It was in an ex-care home, and very important that it was in that facility, because a lot of people have, you know, again, frailty, they need accessible facilities. There was 14 beds, and once you're in there, all the work took place then to sort out your housing, to, you know, do everything, and you had a real discharge to assess, you know. And you know, your homelessness is underpinned, there's so many complex issues, and that was time for assessment and really getting to grips with things. And then once you were there, then you would be rehoused. And again, protocols, they had protocols, all the health service had protocols with the local council, so that if you were coming out of bricks, you were a priority, and there was a protocol, you know, that they would prioritise those cases so that you weren't stuck there. And again, a specialist primary care practice, so they were getting people registered with GPs. So when you look, they had all the mechanism intervention resources for what we assume to be would be effective practice. Oops, sorry. And this is just so you can visualize this, then it's not too abstract. This is brick, so that's the facility where it was. As I say, it was lots of support, I mean, food, company and assessment. So it was a really wonderful place. But that's jumping ahead a bit. So how did we know, how did we test our programme theory about all the jigsaw pieces? Well, we had 3 work packages, and we had, like, this is, I say, we worked with LSE, with Michaela Tinelli at LSE, who did fantastic economic modelling, Rob Aldridge and Andrew Haywood at UCL. And a lot of Martin, Jill, Joe, big gang of us on the qualitative side of things. So to test the programme theory, we did 3 work packages. One was a big qualitative work package where we did in-depth fieldwork in 6 case study sites. And they were 4 sites with a specialist scheme. And each of the 4 sites had a different typology, different pieces of the jigsaw, and 2 sites with just standard care with no scheme. And we basically followed people from when they were admitted to hospital for 3 months to see what was their experience. And that was all about patient experience and patient journey. And then we did lots of interviews with practitioners, managers, asking the question, what works for whom, under what circumstances and why. As I say, the economic evaluation was looking at lots of different multiple modelling, costs invested per day, which of these typologies was most effective, cost effective. And again, a big data linkage with hospital episode statistics and civil death registration. We managed to get data on 3,882 people who'd used the hospital discharge scheme. And then this was telling us the kind of unbiased who got an admission in 28 days. It gives you all the hospital episode statistics that commissioners love. And also things, time from admission to mortality, what was the death rate? The kind of the standard care, we had a bit of a disaster with the control group for the data linkage, in that the control, we chose Find and Treat, which is a service in London, and there's lots of reasons, but that really didn't work. So that was a bit of a disaster. So the data linkage in the end was really just looking at the difference between scheme typologies, and the other control group we used was a cohort of people living in the most deprived areas of England, but we didn't kind of get the data linkage to look at hospital discharge users and non-users. So that's it. And again, public and patient involvement was throughout this week. We had a team who worked with us very much as team members on everything we kind of did. So to jump to the findings, so overall, there was really good evidence from across the 3 work packages to support our programme theory about what worked. And this was about, you need the schemes that are most effective and cost effective are those that have got all the jigsaw pieces. Patient experience, I mean, there was just, you know, the stories of people going to Bradford Bricks was, yes, you know, I was discharged, taxi, cup of tea. Elsewhere, we saw some real shockers, some real horror stories of people. You know, one lady we worked with very closely, discharged in the rain, 8 o'clock at night on a Zimmer frame onto the street. You know, really, there is just no comparison between somewhere safe to stay and going back on the street. You know, again, you know, the intermediate care was shown to be cost effective on every modelling technique, fine. And the data linkage, the really big and the wonderful headline message we were able to get from the data linkage, we could show that people who were going into step down compared to where they didn't have the step down, that was reducing A&E attendances by 18%. And we like use that a lot when we're trying to sell the findings about bricks to commissioners, that wow, you know, headline message. And again, discharge schemes with step down, they increase elective readmissions. So yes, going to bricks does boost readmissions, but they're good readmissions. They're the admissions about planned care, and they're what we want. We want homeless people to get access to care, so they were positive. The final point, again, is about, you know, you do need all the jigsaw pieces. This didn't just show that intermediate care was effective, because we had a lot of areas which just, they set up an intermediate care scheme, spent all the money on the nurses, refurbishing the facilities, and they closed within a couple of weeks because they didn't have any connection to the hospital. Nobody in the hospital was doing the discharge coordination to get the person into the intermediate care. So you really did need every bit of the jigsaw piece was important. And really, this is the kind of lovely message we have flagged up about the importance of homeless. What we've said less about is the bits where it didn't work. And there was quite a lot that troubled the programme theory. And really, what really troubled the programme theory was that when you looked at this big cohort of 3,000 people, you know, the outcomes are still shocking. So 1 in 3 deaths of those people in hospital, in the hospital discharge cohort, are for conditions amenable to timely healthcare. So people who are homeless, they're not just dying of TB and Hep C, they're dying of heart attacks, diabetes, strokes. They're just not getting the same access to primary care as the rest of the population. In the hospital discharge cohort, we also find that people in here, they were 5 times more likely to go back into hospital and 5 times likely to go back in A&E when we compared them to people living in the most deprived areas of England. And across all the sites, we continued to see discharges to the street. And especially the people who got discharged to the street are people who are homeless and they've got addiction problems. So the schemes, they're kind of seeing physical health issues, but any sort of heroin addiction, challenging behaviour, those people ended back on the street. So we've got a mixed picture of like, how do we make sense of this? We've got like really positive findings, but we've got things that are really troubling, that these schemes, they're not having, are they what we call whole systems impact? And this is now where we're coming into the realist evaluation to looking at the mechanisms and the context. And we really sort of our conclusion that we put forward is that outcomes continue to be so poor because of the underfunding of intermediate care. And again, in older people's service, we know that funding remains stubbornly stuck at a level below the threshold for whole system impact. So we know intermediate care works, but there just is not enough of it. We also had the dimmer switch effect, and this is where the schemes, they get the pilot funding, but then the pilot funding runs out, and regardless of whether they work or not, there's just no reinvestment back in them. So there's just not enough of we know what works in the system. And again, in context was it was really, we had schemes that were, they were doing everything like Bradford, they were doing everything right, but the outcomes were terrible. And this was because then there was no housing, there was no community services. So then intermediate care was getting blocked. So really, you can't look at hospital discharge without understanding what's going on in the wider chain. It's not just one area. Really difficult. And really the other big thing, the final thing, is that no change in reasoning. These schemes, hospital discharge schemes, were working because the resources, the extra staffing, the extra money was really important. But at the end of it, we really question to what extent they've actually triggered a change in reasoning in staff and even in people working in hospital discharge schemes. Because basically what we found was that, you know, somebody would be in hospital, the hospital discharge specialist workers, they'd do absolutely everything they could to get somebody housed, to sort them out. And if they got to a point where nothing could be arranged, they would then get an awful lot of pressure from consultants. You knew in a hospital which consultant was sympathetic, which wasn't, and it was get that person out. And you, even though you were an advocate, you didn't stand up, because the more you advocated, the more you stuck up, the more likely you were then to lose your funding because you were a nuisance. And we still saw, so even where there was a homeless hospital discharge scheme, those patients who were sort of into drugs caused a nuisance, they got chucked out as quickly as you can. You know, duty to refer is a bit of a misnomer, because that's just an email to the housing or an I've signposted to the housing. But a lot of people ended up back on the street. Now, the big thing, the kind of a bit of elephant in the room, is that if that happens to an older person, if a care home isn't available for them, we don't chuck them onto the street or send them home. Perhaps we do, but not as much. We keep them in hospital and we delay the discharge. And really, we're making a case that for people who are homeless, that there's still an awful lot of stigma and cultural distance, that they, you know, that they're not as vulnerable, they're not as, you know, so there's a real culture. So this is now just going to be the last slide. And really, this was our final roadmap. This was looking at the different issues. And really, just picking up that point I've made, we had, you know, we've got the discharge protocols, patient in-reach, discharge coordination and intermediate care. But at the end, we've come up the other mechanism, intervention resource that is needed to make this work is strengthening adult safeguarding. We need safeguarding to say, hey, don't chuck homeless people out on the street, delay the discharge. So when we've got two scenarios in areas like Bradford, where there's a good supply of permanent housing, long-term care and support, you know, with those mechanisms, we get consistently safe, timely transfers of care. In areas where we've got those mechanisms, but with no housing and no long-term care, then we need to boost up safeguarding, and we need to actually, ironically, delay transfers of care, because it's only by doing that, you know, in adult social care, when delayed transfers of care go off this Richter scale, that brings investment. But we're not seeing that because of early self-discharge and people going to the street. You know, you don't get the investment because it's just not seen as a problem. So I'll finish now. That was our roadmap. That's our sort of model of practice. We've done a toolkit, which is the references there. We're just in the very final stages of our NIHR report being published, and that's in the final edit. And really, I mean, just as a very positive note, we have had some impact from the research, because we've got a new hospital discharge fund now from the Department of Health. It's 16 million and it's supporting site to try and embed this way of working. So I'm going to be quiet. And just as one last slide was the thing I found most helpful in doing a realist evaluation was the Ramesses guidelines, and in particular the table 5, which was designed for people doing realist review, for peer review, because that was wonderful. It takes you through every step of the way and tells you what's inadequate, good, excellent. Right, Yvonne, I shall stop now. Thank you.
Thank you very much, Michelle. That's absolutely fascinating. We've got all the questions coming through thick and fast, so I'm delighted that we've got a fair bit of time for that. You've answered my question, which I was going to ask, which was what was the most useful resource. So that's great, because that's a really helpful thing to have there. So I think I'm probably going to just start at the top here. Julian Wynne, do you want to ask your question?
Hi.
Here's Julian.
Yes, thank you very much. Hi. Thank you, and thank you for the presentation. It's always good to hear about Realist evaluations being used in other aspects of social science, and I work with a Realist evaluation group in Southampton. I was interested in one of your findings that there had been an 18% reduction in A&E attendances, and I wonder if whether that was specifically an 18% reduction in attendances by homeless people, or was it an 18% reduction in attendances overall? Because I think there's quite a significant difference between the two.
It was 18% reduction in visits compared people out of the 3,000 cohort, comparing those with where there was a step down service compared to where there wasn't a step down service.
Right, so it's specifically related to the homeless cohort.
Yes, to the homeless cohort using a specialist hospital discharge scheme.
Great, thanks very much. I really did enjoy your talk, thank you.
I can see you put another question in there, Julian, but I might come back to that if that's okay.
Yeah, you're quite right. Please me.
Simon Hammond has asked how you presented your programme theory to public patient involvement folk and commissioners, etc. Michelle.
Yeah, well, I mean, the presenting to commissioners, the thing, as I say, we really did. We have, as I say, when we were in the hospital and we were following people, Jo, who was discharged to the street on a gutter frame, which is like a Zimmer frame, we recruited her. We got very close to her and recruited her to the study. And then we went to go out to commissioners. We used to tell the story of the gutter frame challenge, which is Jo's story of she was discharged on a gutter frame and her discharge plan was to go to primary care, get everything. And we followed her, and the expectation was that she would push a gutter frame for 8 miles. So we used to ask her, we used to take the gutter frame laden, and we used to get the commissioners to walk around the room with the gutter frame. And I think of all the models and the thing, it's that had the most impact, that hearing the stories of what it was like to be discharged to the street. So we did a kind of, I think of the dry programme to that.
That's a really powerful way to present things to commissioners. Another question here, is it you, Shin? Are there any differences between Realist review and Realist synthesis? And could we just use Realist synthesis in a systematic review?
Well, I think the most important difference with a Realist synthesis is that you're testing your programme theory. So I didn't do a review of homeless hospital discharge arrangements, a systematic review of that, of everything that's known about that. It was a targeted review. And when we actually did the review, we really look at it because colleagues at Plymouth had done a systematic review of intermediate care for older people. And we basically piggybacked on the back of that. They hadn't looked at homeless people. So then we looked at the homeless literature and built on their theory. So I think, they are the different is the focus. So you're not looking at everything about homeless hospital discharge. You're looking at what's your tentative programme theory, and you're testing that, if that makes sense.
Does that answer the question for you? Not sure where my question has gone on my millions of pages of people in front of me, but I'll take that as a yes for the moment. Nat, you have a question about bricks. Do you want to ask that?
Oh,
I'm hoping it's about the project, not actually about bricks.
Yeah. I don't know if I put the acronym right there, but I was just wondering, what sprung to mind for me, having worked in hospital discharge, was how easily that could also get sort of backed up. I don't know, I was wondering, was it 6-week limit on how long people could stay there? Because I suppose my query is, how are they doing that so well? Where is this housing that people are leaving there to go into? Because I just know a lot of places that wouldn't really be an option, just due to sort of sheer lack of housing options.
Yeah, no, that is the biggest problem, and the biggest thing with commissioners that prevents the commissioning of these services is this belief that it will become blocked and backed up. And bricks was interesting because standard intermediate care is 6 weeks. But these problems in housing are so complex that even 3 months is a push, and people were staying in there for upwards of a year. So it was still a problem. But what was good about Bricks was then they were aware that they've got a patient flow problem. So they were speaking to the council about, right, well, can you prioritise our issues here? And they were, you know, they were doing, like in older people's services, we're much better, aren't we, at like being on top of patient flow. And we know if we've got a problem, we're working the system to address that. And it's trying to get in home. We need to be doing that much better in homelessness. That, you know, there is no, if you're in an area with no housing and no services, it will get blocked up. But the question is, you know, if you don't discharge people to the street and your whole hospital is full of homeless people, then that's a priority. You know, so it's a real, we've got double standards of detox are there for a reason. You know, they're as horrible as they are.
That's great, thank you. With lots of comments in the chat, Michelle, thanking you for your presentation and saying how interesting it is. So Kelly, do you want to ask your question? It's quite complicated, Kelly Hall.
Yeah, thank you for a really useful presentation. Yeah, just realist evaluations tend to be used for kind of very specific interventions. We tend to talk about interventions. And I just wonder if it can be kind of used more broadly. So, for example, could we use realist evaluation to look at whether one type of organisation works better than another or delivers different outcomes to another type? So, for example, I mean, I'm trying to look at if social enterprises in the care sector deliver certain outcomes, and obviously the mechanisms to deliver those outcomes in the context within which they operate. So just wondering about your thoughts around, yeah, how realist evaluation might be used in those kinds of projects.
Yeah, that's what I say in like trying to disseminate the fact there's this issue, you know, realist evaluation isn't really about, is it evaluating an intervention, a mechanism in isolation. I mean, I think, you know, somebody says, doesn't it? It's more about looking at an intervention that works and then looking how you would embed that in other areas. So how do you take a hospital discharge scheme in London and put it in Cumbria? Which bits do you add on? Which bits do you miss off? And again, with ours, you know, it's not, a hospital discharge scheme is not the unit of analysis. It's Bradford. It was the whole of Bradford. It was the system that, you know, because there was two schemes. So we've got mechanism, intervention, resources in the pathway team in the hospital and in the service by Horton. So it's like it's more about like a systems thinking, isn't it? It's not a, you know, but that is the problem, because people do get confused that they want to know which model and what is the bits of the model. And then you say, well, it's not really the model because you've got to look at your context. And does that make sense?
Yeah, thank you. That's really helpful.
Brilliant. We've got a question from Morrow here that's asking if you took account of the impact of delayed discharge on any other essential and urgent admissions in your study.
No, we didn't. No, but that was, you know, this is part of the debate, isn't it? That you know, the clinicians and the, you know, the consultants are very, we can't tackle homelessness. It's not our problem. And that was a bit of the mentality underpinning the discharge to the street then, that, you know, we can't possibly deal with, you know, we block the hospitals up. And I think, you know, with discharge to assess, a lot of the homeless hospital discharge schemes have got to kind of up the game a bit, because it's out on the same day. But so we, you know, we really do need more of these step down facilities, because otherwise there is just nowhere, you know, using hotels is tabled now, isn't it? But a hotel is not as good as a, you know, somewhere like Bricks. So it's like political, and yes, yeah. So no, I didn't consider that, but I think it's part of the politics of it.
Julian, you had a second question. I don't know if you want to ask it or I can ask it for you.
Feel free, yes, but you may wish to choose somebody else from your big audience.
Well, I've got down to the bottom of my questions, although, so there was you had another question, which was about whether there were differences in the way the programme theory worked for homeless people with different kinds of backgrounds. So was there a difference in acceptance or take up between the homelessness with drug related problems versus those with a without a drug or alcohol dependency problem?
So really that just related back to this idea that, you know, does it work for whom, under what circuit, and for the for whom question was that, you know, in hospital, how, you know, the criteria often was, have you got a physical health issue for step down? So a broken leg would be seen as a physical, but a drug and alcohol problem probably wouldn't. And there was like this almost avoidance of people with uncontrolled addictions that, you know, they didn't fit. And even now in the different step down services, it's like there's still a problem of this group of disruptive behaviours. You know, can they go into a, you know, would they go into step down for older people? No, it's like a big, you know, so no, the people who were really benefit were kind of the older, where, you know, they might palliative care, but not necessarily, you know, uncontrolled addiction remains a big issue.
Okay, well, I'll ask one last question then, Michelle. What was the biggest challenge of using realist methodology? Because, you know, it is the big thing at the moment, and you know, and everybody sort of wants to take it on, but it is quite complex. So what would you say was the biggest challenge, and some advice to people who are thinking of using that for their own evaluation? Apart from using the Ramesses guidelines, obviously.
Which were great. I think it's like, you know, the study was, how it came about was a bit, because it started off as, when we first applied to NIHR, it was applied as a realist evaluation with just a qualitative component. But then NIHR came back and said, no, we want cost effectiveness stuff and you must have hard data. So we kind of had a funny mix of it. It was a realist evaluation, but then we had a traditional effectiveness and cost effectiveness kind of evaluation stuck in, and it was quite hard then to get those two bits, you know, to gel together. And I don't think that, you know, the realist bit was fine. You know, the trouble was then it was such a big, 3 big work packages. You know, it was originally 2-year study, but we've just finished it, ended up as 7 years or something, and the costs, and, you know, it was just a big complicated study. But in the end, the adding the effectiveness and cost effectiveness bit in did make it, you know, a lot more robust and better in getting the data. Is that a good, because I find with realist evaluation, it's blagging, isn't it?
Okay. A final call for questions here, otherwise I shall wrap us up.
I could have waffled for longer, couldn't I, really?
You could have gone on for longer, but that's fine. It was as long as it needed to be. It was perfect. Michelle, thank you so much. That was an incredibly helpful presentation, and so nice to have it situated around a project, because I think it can be. Oh, is that you, Liz Wansmore? Are you waving at me? No, you've got a hand up. Oh, is that a clapping thing? There's lots. Okay, I'm not very up on the kind of things that people do. So lots of clapping for you, Michelle. So much appreciated. But yeah, it was just really nice to have it situated around a real example, I think, which really helps. So I'm going to take this opportunity then to just remind people that we have a stats seminar on Friday for those of you that way inclined. Indeed, for those of you not that way inclined, you might learn something. That's about instrumental variables and data visualization in social care research. That's on Friday at 2 o'clock. Our next capacity building webinar on the 2nd of March at 1 o'clock is normalization process theory with Carl May. And also, can I remind people that our annual conference is on the 29th of March, and registrations are open for that. So if you've enjoyed this, there'll be lots more of this sort of thing, and we'd really love lots of people to come to that, because it's all online. It's all very cheap and cheerful, and doesn't cost you very much to attend. So we'd love to see as many people as we can. So thank you all for turning out, and thank you very much again to Michelle.
No, pleasure.
See lots of you again in the future. Thank you very much.
Bye.
Thanks very much. Bye.